Chapter 35 from MedSurg Timby, Caring for Clients with HIV and AIDS. Learning objectives. Explain the term Acquired Immunodeficiency Syndrome, AIDS. Identify the virus that causes AIDS. Discuss the characteristics of a retrovirus. Explain how human immunodeficiency virus, HIV, is transmitted. Name at least 4 methods for preventing transmission of HIV. List 3 criteria for diagnosing AIDS. Discuss the pathophysiologic process of AIDS. List at least 5 manifestations characteristic of acute retroviral syndrome. Name 2 laboratory tests used to screen for HIV antibodies and 1 that confirms a diagnosis of AIDS. Name 2 laboratory tests used to measure viral load and give 2 purposes for their use. Identify categories of drugs that are used to treat individuals infected with HIV and give an example of a specific drug in each category. Give the criterion for successful drug therapy for HIV/AIDS. Discuss the nursing management of a client with AIDS, including client teaching. Describe techniques for preventing HIV infection among healthcare providers who care for infected clients. Discuss 2 ethical issues that affect healthcare providers in relation to clients with HIV infection. Acquired immunodeficiency syndrome, called AIDS, is an infectious and potentially life-threatening disorder that severely compromises the immune system. A pathogen known as the human immunodeficiency virus, HIV, causes AIDS. People can remain well, sometimes up to 10 years or longer, despite being infected with HIV before the initial infection develops into AIDS. During this asymptomatic period, the infected person can infect others. Gerontologic considerations. Treatment advances have resulted in longer lifespans for those who contracted HIV at an early age. HIV is now considered a chronic infection, and infected older adults and their healthcare providers must focus on interaction of HIV and changes with aging, including decreased immunity. Older adults are more likely to be diagnosed later in the course of disease progression with possible immune system damage and earlier death. Efforts to increase older adults' awareness of risk factors prevention and providers' awareness of need for screening may increase earlier identification of infection. Since 2001, there has been a 33% decrease in new HIV infections. Despite the decrease in newly diagnosed people and those who are infected living longer, HIV continues to spread easily from person to person, especially in particular parts of the world, such as sub-Saharan countries of Africa and among specific populations. Based on statistics compiled in 2016 by the Joint United Nations Program on HIV/AIDS, an estimated 36.7 million people are diagnosed with HIV worldwide. Of that number, nearly 70% live in sub-Saharan Africa, where 59% of the world's women with HIV and 90% of the world's children with HIV reside. In the early history of HIV/AIDS, HIV occurred more often among gay men, but that exclusivity is no longer the case. Besides men who have sex with men, those at higher risk are intravenous drug users, transgender people, and prisoners. Infections of heterosexual women leads to transmission of HIV to newborns. To date, nurses are the largest group of healthcare providers to have occupationally acquired HIV infection. Data regarding rates of HIV/AIDS indicate cases and death in people older than 50 years of age remain high, with risk factors similar to other age groups. Early identification and treatment is imperative, and with consideration for other possible comorbidities as well. Globally, an estimated 1.3 million people died from AIDS in 2015, down from 2.3 million in 2005. The decline has been attributed to 1, a change in estimating methods used to calculate statistical data, and 2, educational efforts to decrease behaviors that contribute to HIV infection, and 3, improved antiretroviral drug therapy. Despite the decline in the overall rate of HIV infection and deaths, AIDS continues to be the major health problem in the U.S., especially among white, African American, and Hispanic Americans who have sex with men. HIV. It is speculated that HIV is an altered genetic form of simian, otherwise known as monkey, immunodeficiency virus, SIV. It is believed that the transformation allowed the virus to jump from chimpanzees to humans in Africa when humans slaughtered and consumed the meat of the chimpanzees. Subtypes of HIV. Two HIV subtypes have been identified, HIV-1 and HIV-2. HIV-1 is composed of 4 groups identified as M, N, O, and P. Group M mutates easily and frequently, producing multiple substrains that are identified by letters from A through K, and circulating recombinant form, CRF, a hybrid virus formed by genetic material from various combined subtypes. HIV-2 is the primary type of infection in Western Africa. It is less transmittable, and the interval between initial infection with HIV-2 and development of AIDS is longer. HIV-1, group M, subtype B, is more prevalent in the US and in the rest of the world, but the distribution of subtypes changes from time to time because of the diverse merging of populations. Structural characteristics. Viruses require a living host for survival and duplication. Like all viruses, HIV is genetically incomplete. A double layer of lipid material surrounds the incomplete HIV. A surface-binding glycoprotein called GP120 has projections extending in all directions from the lipid bilayer. The purpose of GP120 is to attach the virus to the T-cell receptors called a CD4 receptor. Another binding protein called GP41, which is composed of 3 stalks, is used to fuse the virus to either the T-cell's co-receptors CCR5 or CXCR4. The discovery of the mechanisms for attachment and fusion with co-receptors has led to the development of antiretroviral drugs called entry inhibitors. The fusion of the virus and CD4 co-receptors provides a means by which the genetic contents within the capsid, the viral structure that encloses the single strands of RNA, along with 3 important enzymes, reverse transcriptase, replication. To replicate, which means to produce more copies, HIV becomes a parasite of helper T cells, known as T4 or CD4 cells, because of their CD4 receptor. HIV alters the helper's T cell's genetic code to make more viral particles. To do this, the enzyme reverse transcriptase copies the viral RNA into the viral DNA. This process is called reverse transcription. A second viral enzyme, integrase, incorporates the reprogrammed viral DNA into the host cell's DNA. The altered DNA tells the cell how to assemble amino acids to form protein substances such as the virus. The transformed DNA provides the blueprint or cookbook for making clones of HIV, along with the enzymes the virus needs to continue reinfecting additional cells. The T cell's nucleus follows the pirated DNA's instructions and forms long chains of viral particles enclosed within its membrane. Protease, the third viral enzyme, cuts the long chains, freeing the replicated viral particles into the cytoplasm of the cell. Some migrate to the cell wall and form buds. When the buds rupture, they release many copies of the virus that reinfect other helper T cells. More than 10 billion viral particles are released daily. Most, but not all, are destroyed. Mutations occur frequently, complicating drug therapy and making production of a vaccine nearly impossible. In February 2005, a new strain of HIV, identified as 3-DCR-HIV, was detected in a gay man in New York. Scientists consider 3-DCR highly virulent because it converts the initial HIV infection to full-blown AIDS in a matter of months. The new strain is highly drug-resistant. The infected man also used methamphetamine, which scientists believe can accelerate the replication of the virus, especially in the brain. AIDS activists are warning people to avoid becoming complacent about the potential for acquiring HIV by stressing consistent condom use, avoiding illicit psychostimulants such as methamphetamine that promote disinhibition and hypersexuality, and adhering to the antiretroviral drug therapy if they have been diagnosed with HIV. HIV transmission. HIV is not transmitted by casual contact. There are only 4 known body fluids through which HIV is transmitted: blood, semen, vaginal secretions, and breast milk. HIV may be present in saliva, tears, and conjunctival secretions, but transmission of HIV through these fluids has not been implicated. HIV is not found in urine, stool, vomit, or sweat. Certain behaviors increase the risk of acquiring HIV from infectious body fluids. Unprotected sexual intercourse and multiple sexual partners increase the risk of HIV infection and other sexually transmitted infections. Using a condom is one of the most effective ways to reduce the risk of HIV. Condoms are available for both men and women. High risk factors for HIV infection: unprotected vaginal, anal, or oral sex, contact with blood and infectious body fluids during medical, surgical, dental, or nursing procedures, sharing intravenous needles or syringes, receiving non-autologous transfusions of blood or blood products before antibodies can be detected in the donated blood. Non-autologous is self-donated. Receiving plasma or clotting factors that have not been heat treated. Contact with infected blood on body piercings, tattoo, and dental equipment. Transmission from infected mothers to infants during pregnancy, birth, or breastfeeding. Before 1984, blood and blood products were a major source of HIV. Since then, an HIV screening test known as nucleic acid testing, NAT, is performed on all blood and plasma donations. Although screening donated blood for HIV antibodies reduces the risk of transfusion-related infection with HIV, it is not flawless. Antibody screening cannot identify injected blood from donors who have yet to produce significant antibodies. The window of time between infection, which is entrance of HIV into the body, and production of antibodies is currently 2.93 days. The National Institutes of Health in 2013 states that the risk for HIV infection in the U.S. from a blood transfusion is approximately 1.5 to 2 million units of blood. 1 in 1.5 to 2 million units. So blood transfusion transmission is approximately 1 in 1.5 to 2 million units of blood. Another potential but less common method of transmission is a puncture with an HIV contaminated needle or other sharp object. Prevention strategies. The transmission of HIV is reduced or eliminated by adhering to the following guidelines: abstain from sexual intercourse, have mutually monogamous sex with an uninfected partner, avoid casual sex with multiple partners, use a condom and spermicide that contains non-oxynol 9 during sexual intercourse, abstain from using IV drugs, especially psychostimulants such as methamphetamine that contribute to disinhibition and hypersexuality, use a new needle and syringe each time IV drugs are injected, refrain from donating blood if engaged in high-risk behaviors, bank self-donated or directed donor blood, specified blood donors among relatives and friends when preparing for non-emergency surgical procedures. Some authorities believe that directed donor blood is no safer than blood collected from public donors. Nurses and other healthcare providers use standard precautions when caring for all clients whose infectious status is unknown. Nurses must immediately report any needle stick or sharp injury to a supervisor. Post-exposure protocols using antiretroviral medications can reduce the risk of HIV infection if initiated within 72 hours after a possible exposure. Prophylaxis requires self-administration of medications once or twice daily for 28 days. Because post-exposure prophylaxis is not 100% effective, condoms should be used until an HIV infection can be ruled out. If infected, healthcare providers can continue to practice. They usually are restricted from performing procedures in which they may exchange blood with clients. Question. A client with AIDS indicates that more teaching about the condition is needed when the nurse hears which of the following statements? A. This disease is spread by sexual contact. B. I'm afraid to touch anyone, I might give them my disease. C. The virus may also be spread through body fluids. And D, infected mothers can pass the virus to their unborn infants. The answer is B, I'm afraid to touch anyone, I might give them my disease. The rationale is the virus is not spread by casual touching, and the client needs to touch others. Classification for HIV infection. Category 1 is T4 cell count greater than or equal to 500. Category 2 is T4 cell count 200 to 499, and Category 3 is T4 cell count less than 200. Category A and B and C. Category A, HIV positive with one or more of the following: no symptoms, persistent generalized lymphadenopathy, which is swollen lymph nodes, acute, primarily HIV infection with accompanying illness or history of acute HIV infection. So again, one or more of the following could occur in Category A. Category B, HIV positive with conditions attributed to or complicated by HIV infection such as bacillary angiomatosis, candidiasis, which is oral or vulvovaginal, which is a yeast infection, persistent, frequent, or poorly responsive to therapy, cervical dysplasia or carcinoma, fever or diarrhea for more than 1 month, hairy leukoplakia, herpes zoster, at least 2 episodes, idiopathic thrombocytopenia purpura, listeriosis, listeriosis, pelvic inflammatory disease, tubo-ovarian abscess, and peripheral neuropathy. Category C is HIV positive with one or more of the following: yeast in the bronchial, tracheal, lungs, or esophagus, cervical cancer, invasive, coccidioidomycosis, which is disseminated or extrapulmonary, cryptococcosis, which is extrapulmonary, cryptosporidiosis, which is for more than 1 month, cytomegalovirus, other than the liver, spleen, or nodes, encephalopathy, HIV-related, herpes simplex for more than 1 month, or bronchitis, pneumonitis, and esophagitis, histoplasmosis, disseminated or extrapulmonary, isopsoriasis for more than 1 month, Kaposi sarcoma, lymphoma, Burkitt's or equivalent, immunoblastic or equivalent in the brain and primary, Mycobacterium avium complex or Mycobacterium kansai, disseminated or extrapulmonary, Mycobacterium tuberculosis, any site, pulmonary or extrapulmonary, Mycobacterium, other species, pneumocystitis carinii pneumonia, pneumonia recurrent, progressive multifocal leukoencephalopathy, Salmonella, septicemia, recurrent, toxoplasmosis of the brain, and wasting syndrome. This table is on page 583. Pathophysiology and etiology. AIDS is transmitted from direct contact with the blood or body fluids of a person diagnosed with HIV or from indirect contact with infected blood or body fluids. When HIV infection occurs, it gradually impairs the ability of infected T4 cells to recognize foreign antigens, which are disease pathogens, and stimulate B cell lymphocytes. While massive numbers of viral particles are being released, infected T4 cells are destroyed by HIV itself and by killer T8 cell lymphocytes that no longer recognize the altered T4 cell's membrane as being itself. Although new T4 cells are produced, the process is never as fast as replication of the virus. Eventually, T4 cells become significantly depleted and immunodeficiency develops. The person who has HIV may ultimately die from an opportunistic infection. The rate of progression from HIV infection to AIDS is related to the concentration of virus in the blood, the subtype and strain of infecting HIV, and the status of co-receptors in the CD4 cells. If inherited abnormalities and mutations in CCR5 or CXC4, co-receptors are blocked with chemokines. chemicals responsible for immune surveillance and immune cell recruitment. There is interference with HIV's entry into the cells. HIV can be prevented from invading cells among individuals who have mutated forms of CCR5 co-receptors that are located inside rather than outside the CD4 cell. For some, the process of progression may take 10 years or more. Although most people infected with HIV die as a result of their disease or an opportunistic infection, a few are long-term survivors. Some explanations for long-term survival include the following. The infectious HIV is a weak strain. The amount of virus is kept low with stronger than normal killer T8 cells. Strict adherence to drug therapy and the combination of drugs used for treatment are highly effective. Assessment findings, signs and symptoms. At the time HIV is acquired, 1/3 to more than 1/2 of those who are HIV positive develop acute retroviral syndrome, viremia, VIREMIA, also called acute HIV syndrome, which often is mistaken for flu or some other common illness. Some manifestations include fever, swollen and tender lymph nodes, pharyngitis, rash about the face, trunk, palms, and sole, muscle and joint pain, headache, nausea and vomiting, and diarrhea. In addition, there may be enlargement of the liver and spleen, weight loss, and neurological symptoms such as visual changes or cognitive and motor involvement. Admission of risk behaviors for HIV narrows the differential diagnosis. Although viral replication is rapid at the time, antibody tests cannot detect the infection. Eventually, individuals with HIV may present with an opportunistic infection or a form of cancer that is atypical for the person's age and health. For example, Kaposi's sarcoma, a type of connective tissue cancer common among those with AIDS, may be noted. Others who acquire pneumocystitis pneumonia have a non-productive cough and shortness of breath. In women, gynecological problems may be the focus of the chief complaint. Abnormal results of the Pap test, genital warts, pelvic inflammatory disease, and persistent vaginitis may also correlate with HIV infection. Testing recommendations. The CDC recommends routine testing for the following populations: all persons aged 13 to 24 years, all persons seeking treatment for an STI each visit, all persons initiating treatment for tuberculosis, all persons with signs and symptoms or illnesses considered consistent with HIV infection. Repeated HIV testing should be performed yearly among individuals at high risk for HIV, such as IV drug users and their sexual partners, persons who exchange sex for money or drugs, and partner of an HIV-infected person, person or partner who has had more than one sexual partner since their last HIV test, and persons starting a new sexual relationship regardless of a previous negative test result. Diagnostic tests, HIV screening tests. Currently, there are screening tests for HIV, as well as tests that confirm an HIV infection. Some screening tests detect only HIV antibodies, the most common of which is the ELISA or EIA test, enzyme-linked immunosorbent assay. In addition, the OraQuick HIV test is a rapid antibody screening test that provides results in 30 minutes or less. The Home Access HIV-1 test can be self-obtained with a finger prick and mailed to a licensed laboratory. A fourth-generation test is a combination test that detects HIV antibodies as well as HIV antigen called P24. The antigen is present before antibodies develop. Because all screening tests can yield false positive results, specimens are retested a second time and an additional test to confirm an HIV infection is obtained. HIV confirmation tests. There are 3 tests that can be used to confirm previously positive screening. The Western blot is the gold standard. It determines antibodies to specific HIV antigens such as P24, GP41, and GP120. A reaction to at least 2 antigens indicates a positive result. The indirect fluorescent antibody IFA test is used when the Western blot test is not definitively positive. It mixes cells that are likely infected with HIV with immunoglobulins and viewed using a fluorescent microscope. Although it can confirm HIV disease, it is expensive and subject to the examiner's interpretation. Lastly, the polymerase chain reaction PCR test, also called an RNA test, is used to detect the HIV virus itself. The PCR test is quite expensive and generally reserved for diagnosing infants with HIV born to mothers with HIV. Miscellaneous tests. A total T cell count, T4 and T8 cell counts, and T4 T8 ratio determine the status of T cell lymphocytes. A T4 cell count of less than 500 per millimeter to the third indicates immune suppression. A T4 cell count of 200 per millimeter to the third or less is an indicator of AIDS. It is now possible to measure a person's viral load, that is, the number of viral particles in the blood. It is used to guide drug therapy and follow the progression of the disease. Viral load tests and T4 cell counts may be performed every 2 to 3 months once it is determined that a person is HIV positive. Other general laboratory and diagnostic tests are prescribed when opportunistic infections are involved. In addition, cancer screening, especially the Pap cervical test for women, are recommended for those with HIV. Immunosuppression tends to facilitate the development of cancer and accelerate its progression. Question. A client with AIDS is unable to cough because of weakness and fatigue. The client is at risk for A. Impaired gas exchange, B. Pain, C. Altered thought process, and D. Ineffective airway clearance. The answer is ineffective airway clearance. The inability to cough results in pooling of secretions and ineffective airway clearance. Gas exchange is not impaired, but the airway is. Medical management. People with HIV and AIDS are treated with antiretroviral drugs, adjunct drug therapy to boost the immune system, and supportive care during opportunistic infections. It's usually recommended that clients infected with HIV receive pneumococcal, hepatitis B, and yearly influenza vaccines. Additional medical management includes treating anorexia, diarrhea, weight loss, and side effects of antiretroviral medications. Research continues on developing an effective HIV vaccine or reducing the potential for infection with microbicide. Antiretroviral drug therapy. The current recommendation is to initiate antiretroviral therapy, regardless of the client's disease stage or CD4 T cell count, T cell lymphocyte count, rather than wait until the cell count decreases significantly. The recommendation is based on the following rationale. Early treatment restores normal CD4, CD8 counts, improves immune function, reduces viremia, the presence of viruses in the blood, delays disease progression, improves overall quality of life, diminishes drug resistance, lessens AIDS-defining illnesses and serious non-AIDS conditions, decreases transmission of HIV to sex partners and prevalence in a community, reduces perinatal transmission, and prolongs life. Gerontologic considerations. Antiviral treatment may accelerate physical changes associated with aging and damage to organ systems, which can increase morbidity and mortality. Besides treating adults and adolescents who are HIV positive, the World Health Organization in 2013 also recommends providing antiretroviral drug therapy to all HIV-infected children under 5 years of age, infected pregnant women, and breastfeeding women. Drug regimens. At present, the majority of drugs used to manage clients drug resistance. The development of drug resistance, ineffective response to a prescribed drug or drug category, called drug cross resistance, because of the survival and replication of exceptionally virulent mutations, limits future alternative treatment options. Clients who neglect to take antiretroviral drugs as prescribed every day, as its designated time, with or without food, as directed, risk development of drug resistance. When drug levels are not adequately maintained, viral replication and mutations increase. In other words, clients who do not follow the drug regimens are one cause of antiretroviral drug failure. It is possible to detect drug resistance with 2 different blood tests. When genotype testing is done, the blood is examined for genetic changes in circulating HIV particles. Scientists now know to look for mutations, in particular codon sequences of DNA. Adjunct drug therapy. Other drugs may be used with antiretroviral drug therapy in an overall attempt to halt the progression of AIDS. One such drug is hydroxyurea, which usually is used to treat cancer. Hydroxyurea inhibits an enzyme that functions in DNA synthesis, thereby inhibiting or slowing the reproduction of tumor cells. When combined with antiretroviral drugs, hydroxyurea interferes with viral replication, increasing anti-HIV effects. In addition, administration of endogenous immune substances known as cytokines, such as interferons and interleukin 2, may also be helpful. Interferons, roferin A and betaseron, activate the cell's own defenses against viruses and are believed to increase blood levels of antiretroviral drugs like retrovir. IL-2 stimulates the production of lymphocytes. The pharmaceutic counterpart of interleukin is used to increase the numbers of T4 cell helper and natural killer lymphocytes. Natural killer lymphocytes specifically target virus-infected cells and cancer cells. Therefore, the use of IL-2 boosts the body's immune system against HIV. Routes of drug delivery. Researchers are attempting to determine whether drugs used in HIV therapy may be delivered other than the oral or parenteral route. The impetus to find alternative drug administration routes is related to the following. The oral route sometimes requires numerous medications taken around the clock on a schedule that requires near perfect adherence to the regimen. The oral route is associated with undesirable GI side effects. The parenteral drugs require self-injection, which many people find objectionable. Funding drug costs. Antiretroviral medications are very expensive, as much as $500,000 per year in the US, and nearly 30% of those with HIV are uninsured. Take into account further that medications are only one portion of an infected person's total healthcare needs. With spiraling healthcare costs involving lab testing and treatment of opportunistic infections, the current expense is logically greater. Medicaid, a state-based medical assistance program for low-income clients, is the largest source of public funding for HIV/AIDS care. Coverage varies from state to state, including criteria that must be met for antiretroviral drug coverage. Eligibility for Medicaid has expanded to include those with incomes at or below the federal poverty level, with the health reforms within the Affordable Care Act. The Affordable Care Act has created health insurance marketplaces in every state to help consumers with information about health plans and prohibits insurers from canceling or withdrawing coverage for pre-existing conditions. Medicare, a low-cost federal medical insurance program, provides funding for medications through its Part D coverage. Medicare enrollees are provided 50% discount on covered brand name drugs while in the donut hole, the point at which funding is temporarily withheld unless and until prescription costs reach a higher preset amount. The Ryan White program funds the AIDS Drug Resistance Program, ADAP, which is administered by the U.S. Department of Health and Human Services. It is the third largest source of funding for HIV in the U.S. for individuals who do not have health insurance that pays for drug therapy. In addition, some social agencies and pharmacies companies have drug assistance and compassionate need programs through which antiretroviral drugs are supplied to people who cannot afford them. Lastly, some may enroll in clinical trials testing new HIV medications that are not yet available by prescription. HIV vaccines. There are at least 20 different HIV vaccine trials in various stages of development and testing. They include the development of preventive vaccines for HIV-negative people and therapeutic vaccines for HIV-positive people to improve their immune system. The most promising investigational study following a previously similar trial in Thailand that proved to be only 31% effective. The new NIH-funded study is slated to begin in 2016 in South Africa. Its target is HIV subtype C, the predominant strain in that area. The challenge in developing a vaccine is the diverse ability of the virus to mutate and hide from the immune system within reservoirs within the body. Microbicide trials. Researchers are developing microbicides, topical drugs that inhibit HIV transmission and either sexually transmitted pathogens by various means, such as increasing vaginal acidity, which is hostile to pathogens, using surfactant detergents to inactivate the virus, or contain the antiretroviral drug dapivirine. Microbicide drugs are in clinical trials mostly in African countries because in these areas men are culturally opposed to using condoms, and HIV drug therapy is beyond the economic means of most people. A secondary goal is to treat a microbicide that is also effective when instilled rectally to protect men who have sex with men. At last report in 2016, a vaginal ring containing dapivirine reduced the risk of HIV infection by 61% among women aged 25 and older who used the ring consistently. Supportive care of opportunistic infections. Clients with AIDS acquire many infectious disorders, some of which can cause death. These infectious disorders, and their comparative severity are uncommon in populations of relatively healthy people. The management of some common infection conditions is discussed in the following sections. On page 592, figure 35.9, opportunistic infections occur when the immune system is severely damaged. These infections cause life-threatening illnesses in people with AIDS. A partial list of some of the infections and cancers associated with AIDS is shown along with some of their symptoms. Again, page 592 in the MedSurg book. Pneumocystitis pneumonia. Clients infected with HIV are at particular risk for acquiring pneumocystitis pneumonia, a type of pneumonia caused by an organism called Pneumocystis carinii, which has been renamed Pneumocystis jirovecii, Jiroveci, to distinguish it as an organism that specifically infects humans rather than one that is common to other species of mammals. This type of pneumonia is rare among individuals with an intact immune system. The pneumonia can become so severe as to result in respiratory failure. Mechanical ventilation may be necessary to sustain adequate pulmonary function. Aerosol therapy and deep suctioning often are necessary to clear the lungs of thick sputum. To prevent and treat pneumocystitis pneumonia, Bactrim and Septra is prescribed. Monthly aerosolized pentabene isothianate, which is called Nebupent, is also effective. Candidiasis is a yeast infection caused by Candida albicans microorganism. Candidiasis may develop in the oral, pharyngeal, esophageal, or vaginal cavities or in folds of the skin. It's often called thrush when located in the mouth. Inspection of the mouth, throat, or vagina reveals areas of white plaque that may bleed when mobilized with a cotton-tipped swab. When candidiasis affects structures of the mouth and throat, it can lead to problems with eating and subsequent weight loss. Topical antifungals such as nystatin are useful for treating oral candidiasis. They are available in an oral suspension that is swished in the mouth and then swallowed, or in a lozenge form. Gyne-lotrimin and Misalex and monostat cream, vaginal tablets, and suppositories are used to treat vaginitis. Sometimes systemic antifungals such as fungazone or diflucan are required to control candidiasis. Cytomegalovirus infection. Opportunistic infections caused by the CMV, the cytomegalovirus, affect immunosuppressed people such as clients with AIDS. CMV can infect the choroid and retinal layers of the eye, leading to blindness. It can also cause ulcers in the esophagus, colitis and diarrhea, pneumonia, and encephalitis. Foscavir, Vistide, and cytovine are used in combination aggressively to treat acute CMV infections. Maintenance drug therapy follows to reduce the potential for future viral activation. Cryptosporidosis. Immunosuppressed clients may develop severe diarrhea as a result of infection with a protozoan called Cryptosporidium. The organism is spread by the fecal-oral route from contaminated water, food, or human or animal waste. Those infected can lose from 10 to 20 liters of fluid per day. Losing this massive amount of fluid quickly leads to dehydration and electrolyte imbalances. When diarrhea is accompanied by anorexia, nausea, and vomiting, weight is difficult to maintain. Definitive diagnosis is made by examining the stool for ova and parasites and other cytologic examinations. Antibiotic therapy is then implemented. The macrolide family of antibiotics such as Zithromax, Biaxin, or an approved antiprotozoal agent, Humatin, is used. AIDS-related complications. Besides AIDS-related cancers and opportunistic infections, clients may develop AIDS dementia complex, ADC, sometimes called HIV-associated neurocognitive disorders, abbreviated HANDS. ADC, a neurologic condition, causes degeneration of the brain, especially in areas that affect mood, cognition, and motor function. Clients exhibit forgetfulness, limited attention span, decreased ability to concentrate, and delusional thinking. Moods range from irritability to euphoria. A possible motor dysfunction is manifested by a staggering gait and muscle incoordination, slowing all movements, or paraplegia, which may be accompanied by incontinence. The dementia caused by AIDS may be mistaken for other dementias that may affect older adults and may occur concurrently. Antiretroviral therapy can delay or prevent AIDS dementia complex. Other drugs, some of which are in clinical trials, may slow the progression of ADC once it manifests. One such drug is memantine, called Namenda. It is believed that this medication performs a neuroprotective function. Memantine blocks NMDA, the N-methyl D-aspartate receptors in the brain, from being overexcited by the neurotransmitter called glutamate. Normal concentrations of glutamate enhance memory and learning. Too much glutamate is lethal to brain cells. Research also continues on CPI-1189, an agent that is antagonistic of cytokines such as tumor necrosis factor, which are produced during GP120-induced inflammation of brain cells. Until more definitive studies are conducted, however, these drugs may be combined with antiretroviral cocktail therapy or with Eldepril, an anti-Parkinson's drug, to treat motor and cognitive impairments of ADC, and with psychiatric drugs to moderate mood and activity levels. Other clients may develop distal sensory polyneuropathy, DSP, which is characterized by abnormal sensations such as burning and numbness in the feet and later in the hands. Because neuropathy is a side effect of several antiretroviral drugs, it is difficult to determine if the cause is actually destruction of the sensory peripheral nerves or drug therapy. DSP responds less well to drug therapy than do neuropathies associated with other primary disorders such as diabetes mellitus. Nevertheless, an effort is made to preserve and promote nerve function using vitamin B12 and thiamine supplementation. Neuropathic pain may also be amenable to treatment with tricyclic antidepressants such as Elavil, Pamelor, or anticonvulsants such as gabapentin, also called Neurontin, carbamazepine, which is called Tegretol, or pregabalin, which is called Lyrica. Nursing management. The role of the nurse involves health teaching and counseling high-risk populations. The areas of emphasis include HIV prevention strategies such as sexual abstinence and safer sex practices, sexual activities in which body fluids are not exchanged. The nurse encourages diagnostic screening for those whose behaviors place them at risk for HIV infection. He or she interprets the results of diagnostic tests and monitors the need for continued follow-up in the months after potential exposure. AIDS education. When educating clients with AIDS, the nurse should emphasize the importance of following safer sex practices. For clients with an established HIV status, the nurse explains the action of each antiretroviral drug and develops a schedule for the client's self-administration. This includes strong precautions about the rigidity adhering to the dosage, time, and frequency of drug administration to avoid the development of drug resistance. Describing the side effects of drug therapy is essential, with the admonition to refrain from discontinuing any of the prescribed drugs without first consulting the prescribing physician. The nurse makes appointments for laboratory tests for monitoring the effects of drug therapy. Referral of HIV-positive clients to support groups and resources for information about the new HIV drug development, clinical drug trials, ADAP, and progress on vaccine development is a very important nursing intervention. HIV Education and prevention efforts in the U.S. have focused on increasing HIV prevention and surveillance of older adults. The goal of the National HIV/AIDS Strategy is to increase healthcare providers' awareness, discussions, education regarding sexual activity, and support for older adults with HIV/AIDS. Reducing occupational risks. The nurse must observe standard precautions whenever there is a risk of exposure to blood and body fluids. He or she must follow the nursing guidelines for safe handling of needles and sharp instruments. The Occupational Safety and Health Administration also recommends the following when caring for all clients, regardless of their infectious status: transport specimens of body fluids in leak proof containers, clean, disinfect, or discard utility gloves used for cleaning. Remove barrier garments such as face shields, glasses as soon as possible after leaving a client's room. If exposed to the blood of any client, the nurse should report the incident to the person in charge of employee health immediately. The nurse will be tested for HIV at regular intervals and treated with antiretrovirals depending on the results of tests or the potential for infection. While awaiting the results of diagnostic tests, the nurse must follow the same sexual precautions as someone who has been diagnosed with AIDS. Safe handling of needles and sharp instruments. Do not become distracted when handling needles and sharp instruments. Concentrate on the task being performed. Use a clean tray to pass used or contaminated needles and sharp instruments to another person. Keep the container for disposal of needles and sharps close by. When necessary, carry the container to the bedside. If a client is uncooperative, ask for assistance when obtaining blood specimens, handling body fluids and secretions, giving injections, or starting IV therapy. Do not leave uncapped or used needles unattended. Properly dispose of contaminated sharp instruments and needles as soon as they are used. Client teaching. For clients who are healthy enough to continue as outpatients, the nurse develops a teaching plan that includes the following. Understand that antiviral drugs do not cure HIV/AIDS but may slow its progression. Follow the medication schedule religiously. Do not omit or increase the dose without physician approval. Follow the timing of antiviral medications around meals. Eat small, frequent, well-balanced meals. Try to maintain or gain weight. Drink plenty of water. Check weight weekly. Report progressive weight loss or loss of appetite to the physician. Avoid exposure to people with infections, including colds, sore throats, upper respiratory tract infections, and childhood diseases such as mumps and chickenpox, and people who have recently been vaccinated. Avoid crowds. Notify the physician if signs of infection such as fever, sore throat, diarrhea, respiratory distress, and cough occur, or if signs of a skin, rectal, vaginal, or oral infection appear. Wear gloves and mask when disposing of animal excretions such as kitty litter, birdcage liners, and hamster shavings. Wash hands thoroughly afterward. Wash all foods before cooking. Do not eat raw meat, fish, or vegetables, or food that has not been completely cooked. Wash bedding and clothes in hot water and separate from the laundry of others, especially if the bedding and clothes are soiled with body secretions. Avoid smoking or exposure to secondhand smoke. Bathe or shower daily. Wash hands before and after preparing food. Clean the anal and perineal areas well after each bowel movement, and wash hands after voiding or defecating. Personal cleanliness is a must. When possible, avoid dry and dusty areas, excessive humidity, and extreme heat or cold. Wear clothing appropriate to the weather and temperature. Take frequent rest periods and space activities to prevent fatigue. Do not share IV needles and do not donate blood. Inform healthcare providers of HIV positive status. Question. A client with AIDS is at risk for imbalanced nutrition related to anorexia, nausea, or mouth sores. Nursing interventions that may help alleviate symptoms that interfere with intake or nutrient use include all of the following except A. Encourage small frequent meals. B. Provide low-fat, high-carb meals to clients experiencing nausea and vomiting. C. Restrict fluids to promote ease of swallowing in clients with oral ulcerations. D. Avoid lactose, residue, fat, or caffeine to prevent diarrhea. The answer is C. Restrict fluids to promote ease of swallowing in clients with oral ulcerations. Liquids should be encouraged to replace fluid and electrolyte losses. Very hot or very cold foods can irritate the mucosa. Room temperature foods and liquids are recommended for clients with a sore mouth. Understanding financial and insurance implications.